Hello dear friends, how are you doing today? I hope you are doing well. Today we are going to talk about uncommon eczematous-appearing disease. Darier disease. Darier disease, also known as keratosis follicular, is a rare chronic autosomal dominant genodermatosis caused by pathogenic variants in the ATP2A2 gene, which encodes the SERCA2. This defect impairs intercellular calcium homeostasis, leading to endoplasmic reticulum stress, keratinocyte apoptosis, and abnormal epidermal differentiation. Clinically, Darier disease is characterized by persistent or recurrent hyperkeratotic, crusted, or keratotic papules and plaques, predominantly affecting seborrheic areas such as the scalp, face, neck, and upper trunk. Lesions may be malodorous and are often exacerbated by heat, sweating, UV exposure, and mechanical irritation. Nail abnormalities and mucosal involvement are common, and nearly half of patients develop flat-top papules, indistinguishable from acrodermatitis, verruciformis, or HOPE, and allelic disorder. Histopathologically, this disease is marked by acantholysis, dyskeratosis, and the presence of apoptotic keratinocytes, also called corpse rods. The chronic skin barrier defect predisposes to secondary bacterial and viral infections, and there is an increased risk of keratinocyte carcinomas, particularly basal cell carcinoma. Systemic associations have been reported, including increased risks of neuropsychiatric disorders such as bipolar disorder, schizophrenia, and intellectual disability, epilepsy, neurodegenerative disease, and heart failure, reflecting the ubiquitous expression of SERCA2 and the systemic impact of ATP2A2 mutations. Management is primarily symptomatic, focusing on avoidance of triggers, skin care, and prevention of superinfection. Topical therapies, including corticosteroids and antiseptics, are used for mild disease, while systemic retinoids are the mainstay for extensive or refractory cases. Emerging evidence suggests that targeting the interleukin-23-interleukin-17 axis may benefit patients with severe therapy-resistant disease. Darier disease, red patch with annular crusted border. Glucagonoma syndrome. Glucagonoma syndrome is a multi-system disorder characterized by migrating erythematous, scaling, and crusted papules, patches, and plaques, along with the occasional vesicle and pustule. The skin biopsy demonstrates characteristic superficial epidermal necrosis. Hence, this condition is also known by the descriptive name necrolytic migratory erythema. The eruption is periorificial, flexural, and acral with associated glossitis. It is caused by a pancreatic tumor of the islet alpha cell, which secretes raised plasma glucagon levels. Besides the skin findings, patients with this syndrome also have weight loss, anemia, diarrhea, and diabetes. Glucagonoma syndrome, pink, scaly, slightly crusted lesions. Langerhans cell histiocytosis. Langerhans cell histiocytosis is an neoplasm of Langerhans cells that affects the skin, extracutaneous organs, particularly bone, bone marrow, spleen, liver, lungs, central nervous system, and lymph nodes. It can be acute and disseminated, chronic and multifocal, and localized. The acute disseminated form typically presents in infancy and involves the scalp, trunk, and intertriginous areas. Recalcitrant diaper dermatitis. There are tan, pink, sometimes hemorrhagic papules, and scaling, slightly eroded patches. The skin biopsy demonstrates a proliferation of Langerhans cells in the epidermis and dermis that stain with S10 antibody and are seen on electron microscopy to contain Berbeck granules. Langerhans cell histiocytosis, red, slightly eroded patches. Lichen sclerosus. Lichen sclerosus is a chronic inflammatory mucocutaneous disorder with a predilection for the anogenital region. Though extragenital involvement occurs in a minority of cases, the etiology remains incompletely understood. Current evidence implicates autoimmune mechanisms in genetically predisposed individuals with additional associations, including hormonal status, notably postmenopausal women, and trauma, also called Kobner phenomenon, and less consistently preceding infections. Clinically, lichen sclerosus typically presents as well demarcated porcelain white atrophic plaques, often accompanied by pruritus, soreness, and in advanced cases, fissuring, erosions, and scarring. In women, this may result in architectural distortion, example labial fusion, introital stenosis. In men, phimosis and metal stenosis may occur. Asymptomatic cases are not uncommon, and extragenital lesions may be seen in up to 20% of patients. Diagnosis is primarily clinical based on characteristic morphology and distribution. Skin biopsy is reserved for atypical presentations, treatment, refractory disease, or suspicion of neoplasia. Histopathology reveals epidermal thinning, basal cell degeneration, homogenization of the upper dermal collagen, and a band-like lymphocytic infiltrate. First-line therapy is a long-term application of ultra-potent topical corticosteroids, example clobetasol, propionate, which are effective in inducing remission and preventing progression. Maintenance therapy may be required to prevent relapse. Topical calcineurin inhibitors, example tacrolimus, pimecrolimus, are considered in corticosteroid refractory cases or when corticosteroids are contraindicated. Surgery is reserved for complications such as severe scarring or malignancy in men. Circumcision may be indicated for persistent or functionally impairing disease. Long-term complications include destructive scarring, sexual and urinary dysfunction, and an increased risk of anogenital squamous cell carcinoma, also called estimated at 4 to 6% for vulvar lichen sclerosus. Lifelong surveillance is recommended due to the risk of malignant transformation and recurrent disease. Lichen sclerosus red, slightly whitish confluent macules and plaques. This photo is showing extragenital lichen sclerosus and histopathology of lichen sclerosus. Pemphigus foliaceus. Pemphigus foliaceus, a rare milder form of pemphigus, is an autoimmune blistering disorder characterized by the production of pathogenic IgG autoantibodies directed against desmoglein 1, a cadherin type cell adhesion molecule found in the upper layers of the epidermis. This leads to loss of keratinocyte adhesion, or so-called acantholysis, and results in superficial fragile blisters that rapidly rupture, leaving erosions, scaling, and crusting, most commonly affecting the face, scalp, and seborrheic areas of the upper trunk. Unlike Pemphigus vulgaris, mucosal surfaces are typically spared in Pemphigus foliaceus, and intact blisters are rarely seen due to the subcorneal level of epidermal splitting. Clinically, lesions may resemble severe seborrheic dermatitis, Darier's disease, or erythrodermic presentation seen in atopic dermatitis, psoriasis, or drug eruptions. The Nikolsky sign is usually positive and lesions heal without scarring, but may result in post-inflammatory hyperpigmentation. Erosions are susceptible to secondary bacterial or viral infection. Histopathology reveals a subcorneal split with acantholysis, and direct immunofluorescence demonstrates intercellular IgG deposition in their epidermis. Serologically, anti-desmoglein 1 antibodies are present, while anti-desmoglein 3 antibodies are typically absent or at low levels. distinguishing Pemphigus foliaceus from other Pemphigus subtypes. The pathogenesis involves both humoral and cellular immune mechanisms, with evidence supporting a role for apoptosis and caspase activation in the development of acantholytic blisters. First-line therapy consists of systemic corticosteroids, often combined with immunosuppressive agents. Rituximab is increasingly used as a steroid-sparing agent and may become first-line therapy in the future. Alternative treatments such as apremilast have been reported in isolated cases for mild disease, particularly when conventional immunosuppression is contraindicated. Pemphigus foliaceus red slightly scaling papules and small plaques. Wiskott-Aldrich syndrome. Wiskott-Aldrich syndrome is a rare X-linked recessive disorder that may appear like atopic dermatitis. Recurrent severe infections suggest an immunodeficiency that is characterized by increased IgA and IgE levels, decreased IgM concentration, and impaired cell-mediated immunity. Petechiae and bleeding episodes are a manifestation of thrombocytopenia as well as platelet dysfunction. Infection, bleeding, and lymphoreticular malignancy are causes of childhood death in these patients. Wiskott-Aldrich syndrome, diffuse pink and petechial papules and macules. Zinc deficiency. Zinc deficiency is an inherited or so-called acrodermatitis, enteropathica, or acquired or parenteral nutrition condition characterized by perioral genital and acrodermatitis plus diarrhea. It usually begins in infancy with the diagnosis confirmed by low serum zinc levels. Essential fatty acid and biotin deficiencies have similar dermatitis appearance. Zinc deficiency, reddish perioral erosion, or so-called acrodermatitis. Clinical case. This 40-year-old man was using povidone iodine ointment dressings on a non-healing wound. 2 weeks after starting this therapy, he developed a markedly pruritic eruption under the dressing. The physical examination revealed a 3 cm necrotic ulcer with a surrounding erythematous papullo-vesicular rash conforming to the rectangular area covered by the povidone iodine dressing. What is your differential diagnosis? This acute eczematous eruption confined to the area beneath the dressing is typical of contact dermatitis. A less likely cause would be a fungal or bacterial infection since pustules are absent. How would you treat this patient? The dermatitis cleared when the povidone iodine dressings were replaced with saline compresses and a topical steroid cream. How would you prove your diagnosis? The patient had no history of iodine sensitivity. However, he had been applying the povidone iodine dressing for 2 weeks, which is sufficient time to develop sensitivity to this compound. A patch test to 10% povidone iodine solution was positive, confirming the diagnosis of allergic contact dermatitis. Important points. Topical medicaments are an important cause of allergic contact dermatitis and should be suspected when an eczematous eruption occurs in areas that conform to application of the medication. Avoidance of the allergen is the treatment of choice. Topical steroids hasten the resolution of allergic contact dermatitis. Patch testing confirms the diagnosis of allergic contact dermatitis.